I'm going to discuss basic concepts and features of odontogenic myxoma. Myxoma, as a term indicates, a tumor of connective tissue which contains large number of myxomatous tissue. So myxoma essentially is a benign tumor and it is very common in heart, also called as cardiac myxoma. Histopathologically contains mucus-like areas with collagen fibrils and small number of angular cells. Myxomas are also seen in blood vessels, muscles, and bones. In muscles, these are called as intramuscular myxomas, whereas in bones, these were earlier called as osteogenic myxomas. The term osteogenic myxoma is not used now, and the myxomas are very rare in bones. Now, coming to myxoma in jaws. In oral cavity, myxoma can cause swelling. They are largely asymptomatic, aggressive. They penetrate marrow spaces. There are characteristic histopathological features seen. They contain myxoid with star-shaped cells. These cells anastomose with one another and sometimes epithelial rests are seen. As these odontogenic myxomas contain epithelial rests histopathologically and can arise from dental papilla, dental follicle, or follicular ectomesenchyme. So the term used is odontogenic myxoma. Odontogenic myxoma is an ectomesenchymal odontogenic tumor. Odontogenic myxoma is an intraosseous neoplasm. It is aggressive, it penetrates marrow spaces. The myxomatous tissue invades surrounding normal bony trabeculae. So overall there is high recurrence rate compared to other benign tumors, and it is necessary to have aggressive treatment for odontogenic myxomas. Clinically, these are seen in young adults. The average age ranges from 25 to 30 years, equally seen in both males and females. The mandible is slightly more affected than maxilla, and small lesions are asymptomatic and detected by routine radiography. If odontogenic myxomas are large, then they cause facial asymmetry. Generally, there is painless expansion of bone and it causes displacement of surrounding teeth. Maxillary odontogenic myxomas need special consideration because the lesions can penetrate bone, spread in maxillary antrum, and fill entire antrum. Maxillary antrum odontogenic myxomas can cross midline septa and invade in opposing sinus cavity. There can be associated exophthalmos and nasal obstruction, particularly in case of large maxillary odontogenic myxomas. Radiographic appearance, there can be radiolucency, which is unilocular or multilocular. The multilocular radiolucency can have honeycomb appearance or sometimes soap bubble appearance. Soap bubble when this radiolucency is large. There can be displacement or resorption of teeth in the area of the tumor. The margins of radiolucency are irregular or scalloped. Sometimes the radiolucent defect can contain wispy trabeculae of residual bone. These are arranged at right angles to one another, so the term used is spiderweb-like appearance or tennis racket-like appearance. Histopathologically, odontogenic myxomas, as other myxomas of the body, contain loose myxoid appearance of stroma. The stroma contains few collagen fibrils. There is abundance of stellate, spindle, or round cells in stroma, which are anastomosing, and rarely islands of inactive appearing epithelial rests are seen. The ground substance is composed of glycosaminoglycans, which contains hyaluronic acid and chondroitin sulfate. Odontogenic myxomas resemble giant cell granulomas, aneurysmal bone cyst, and chondromyxoid fibroma. Radiographically, odontogenic myxomas resemble ameloblastoma and calcifying epithelial odontogenic tumor. Central neurilemoma clinically can resemble odontogenic myxoma. As odontogenic myxomas are not encapsulated, they tend to infiltrate the surrounding bone. The complete removal by curettage is often difficult, so there is need to remove surrounding bone. The odontogenic myxomas in posterior jaw, particularly maxillary odontogenic myxomas, are treated more aggressively. Although the prognosis is good, but there are chances of high recurrence. And according to some studies, the recurrence can be as high as 25%. As it is a benign tumor, the metastasis doesn't occur. Now to conclude some of the multiple choice questions. Question number 1, odontogenic myxoma is, option number E is incorrect, it is an ectomesenchymal odontogenic tumor. Option number B is correct, aggressive lesion. Option number C is not correct because it invades bony trabeculae. And option number D again is not correct because it is benign tumor. So option number B is the correct option. Odontogenic myxoma is aggressive lesion. Tennis racket appearance is seen in, option number C is correct. Tennis racket appearance is seen in odontogenic myxoma. It is not seen in fibrosarcoma, osteosarcoma or bony dysplasia. Question number 3, odontogenic myxoma histopathologically contains angular cells, myxomatous cells, small number of collagen fibrils, all of the above. All of the above is the correct option. True about odontogenic myxoma, it is aggressive tumor. Option number C is correct. There are many chances of recurrence. It can be as high as 25%. So option number A is wrong. Is not treated by simple curettage. Again, option number B is wrong. Long-term follow-up is needed. So option number D is wrong. It is an aggressive tumor. Thank you.